The blood pressure number hanging on your doctor's wall was built for the arteries of a 40-year-old, and I have the evidence sitting in front of me right now. Not tweaked for aging vessels, not loosely adapted from middle-age data, but engineered from the ground up for a body 3 decades younger than yours. I have spent my career watching adults over 70 get squeezed into a target their circulation cannot tolerate, and I have witnessed exactly what unfolds when that artificial number wins. I watched a 73-year-old woman who gardened every morning trade her trowel for a walker because her physician obeyed a guideline instead of the person breathing in the exam room. I sat beside a husband who spent 42 days in a rehab bed after a reading of 124. A number his doctor circled and labeled optimal dropped him onto the bathroom tile. Everything you have absorbed about what your pressure should read after 65 is dangerously incomplete. The web floods you with absolute statements about blood pressure benchmarks. Lower equals healthier. Drive that systolic below 120. 1 medication insufficient. Layer on a second. 2 not doing the job. Pile on a third. Keep compressing the digits until the printout glows with perfection. It is worthless advice. Your circulatory system is not a spigot you twist clockwise until the stream suits you. The goalpost shifts with age. You cannot keep cranking the figure downward and assume a 78-year-old body with rigid, sluggish pipework will manage the strain the way a 40-year-old body with supple, responsive tubing manages it. That is not biology. And I know this because I have tracked what actually unfolds inside the tissue when the measurement plunges too far in a frame never constructed for that objective. At 40, your vascular network is responsive. It possesses snap. It lengthens and recoils like fresh elastic, immediate, without lag. When you rise from a seated position, gravity yanks your blood volume toward your feet. Your system registers the shift within milliseconds. The conduits constrict, the pump accelerates. Blood gets thrust back upward toward your skull before your conscious mind registers the movement. The correction consumes under a single second. Your cognition never skips a pulse of fuel. By 70, those pipes have remodeled. The elastin fibers inside the walls have fractured. Collagen has cross-linked and toughened. The muscular layer that used to cinch the vessels tight in a split second now labors like wading through honey. The rubber band has aged. It has endured 70 years of cyclic stretching, and it no longer recoils. It crawls. When you rise and gravity drains the blood downward, the vessels attempt to clamp, but they lag 3 to 5 seconds behind. During that 3 to 5 second window, your cerebral cortex is operating on fumes. The oxygen thins, the metabolic fuel dips, the environment blurs, the horizon tilts. Your hand shoots toward the doorframe, your peripheral field narrows, and then gradually, the vessels catch up, and the perfusion returns and the space stabilizes. That is your baroreflex mechanism failing to match gravity's pull, and it replays every single time you stand. Now absorb this piece. Every antihypertensive agent you swallow nudges the resting pressure lower. A lower starting point means the standing dip plunges deeper. A deeper plunge means the brain receives less perfusion for a longer stretch. A longer stretch means the odds of collapse multiply. The capsule intended to shield your myocardium is widening the deficit that starves your neurons each time you lift off a seat cushion. That is not an adverse event. That is a blueprint failure baked into a goalpost never validated for your physiology. This impacts roughly 1 in 3 adults past 65. In assisted living environments, the prevalence climbs to 65%, nearly 2 of every 3 residents, and 1 in 5 adults who shatter a hip after 70 do not survive 12 months. Not from the osseous injury itself, but from the cascade that ignites. The pulmonary infection from prolonged recumbency, the thrombi from stasis, the wound sepsis from operative intervention, the sarcopenia that evaporates from weeks confined to a mattress. The fracture is domino 1. The palm that tipped domino 1 was a blood pressure benchmark calibrated for a vascular system 3 decades younger. If you intend to shield yourself, you must grasp the mechanism. Because the moment you comprehend why this parameter behaves differently past 65, the moment you recognize that the target your clinician references ignores your arterial aging, you will see that the adjustments I am about to outline are not generic wellness tips. They are precision countermeasures. The orthostatic challenge activates a distinct diagnostic circuit. The parameter modification targets a defined safety band. The pharmaceutical discussion initiates a focused clinical reassessment. This is applied hemodynamics. This is published evidence. This is the method for abandoning a chart and defending a living organism. Stay present, because by the conclusion of this material, you will grasp precisely what is occurring inside your arterial walls at this moment. You will grasp why the most influential hypertension trial in modern history systematically removed the very adults who required its protection the most. You will grasp why forcing your systolic below 130 may be inflicting greater harm than the elevated pressure it aims to correct. And you will grasp what cerebral hypoperfusion does to your cognition across months and years of transient dips that nobody quantifies. This is not conjecture. This is peer-reviewed physiology, and it delivers. But first, you need to comprehend what the autoregulatory apparatus actually performs, because if you do not understand the system, you cannot advocate for the correct endpoint. When you assume an upright posture, gravity displaces roughly 500 to 800 milliliters of blood downward into the lower extremities within heartbeats. That approaches a full liter departing your thorax. Your organism possesses a reflex architected to intercept this. Baroreceptors, situated in your carotid sinus and aortic arch, sense the pressure decrement and discharge an afferent volley to your brainstem in a fraction of a heartbeat. Your central processor returns an efferent command to the vascular smooth muscle, directing it to contract. The resistance vessels squeeze, the cardiac pace accelerates, the column of blood propels back upward. In a 40-year-old, this complete loop, sense, transmit, constrict, compensate, completes in under 1 second. You do not perceive a thing. In a 75-year-old, the sensors are blunted. They register the decrement tardily. The afferent transmission creeps. The central integration lags. And the vessels commanded to constrict are too fibrotic to answer briskly. The loop that required 1 second at 40 demands 3 to 5 seconds at 75. Throughout that interval, the brain receives up to a 20% deficit in perfusion relative to metabolic demand. That 20% is the vertigo. That 20% is the pre-syncope. That 20% is the 3 seconds of void that sent Margaret to the ground. If you take pressure-lowering medication and you experience wooziness upon standing, type the word wooziness in the commentary section immediately. I want to quantify how many of you are residing inside that gap. Now, let me recount Margaret's case, because her narrative is the story of a structure that failed a patient by executing its own protocols flawlessly. Margaret was 73. Her pressure sat at 151/91. Her physician deemed it excessive. The algorithm dictated driving the top digit below 130. The physician layered a calcium channel blocker onto the existing angiotensin receptor blocker Margaret already consumed. Within 2 months, her pressure clocked 124/76. The physician glanced at the record and uttered a single term: perfect. Margaret volunteered nothing. She lodged no grievance. She omitted that the environment swam each time she rose from her sewing table. She omitted that she clutched the shower grab bar at every pivot because the room lurched for 3 seconds before stabilizing. She omitted that she had abandoned her raised garden beds because the uneven flagstone path rendered her precarious. She omitted the shower stool she purchased because she dreaded slipping on wet porcelain. She credited it to advancing years. No one informed her the capsule was the culprit. On a Thursday morning in early spring, Margaret rose from her armchair to retrieve the landline. The blood drained from her cranium. The visual field collapsed. 3 seconds of absence. She crumpled laterally into the edge of the end table, impacted the hardwood, and fractured her right femoral neck. Her daughter discovered her supine with the receiver emitting a dial tone from the countertop, and she did not cry out because somewhere deep in her somatic awareness, she had anticipated this moment for half a year without permitting the thought to surface. Paramedics transported her. Margaret endured surgery, then 4 weeks in a skilled nursing facility. Each dawn, a rehabilitation specialist guided her to vertical and assisted 3 shuffling steps with a wheeled frame before returning her to the mattress. 3 paces. This was a woman who deadheaded roses and hauled bags of soil every weekend without a second thought. Now, 3 steps with an elbow brace felt like summiting a peak. Her daughter visited daily. She occupied the vinyl chair beside the mechanical bed. She held her mother's hand. They watched daytime programming. They discussed nothing about the pressure or the capsule or the benchmark or the term perfect because no conversation could convert those 3 supported steps back into hands buried in garden loam. Margaret navigates with a rollator now. The raised beds have gone to weeds. She does not shower unsupervised. The pressure that delivered her to the floor was 124/76. The exact digits her physician stamped perfect. Now, absorb the segment that ought to stir your indignation. The blood pressure threshold that dismantled Margaret's independence originated from a megatrial called SPRINT, among the most ambitious hypertension investigations ever mounted. SPRINT pitted intensive pharmacotherapy, forcing systolic below 120 against conventional management, maintaining below 140. The trial concluded that intensive treatment curtailed myocardial infarctions and cerebrovascular events, genuine outcomes, meaningful outcomes. However, SPRINT systematically barred adults residing in long-term care, barred adults carrying a diabetes diagnosis, barred adults whose upright pressure already dipped beneath 110. It surgically excised the precise population most susceptible to the collapses and the osseous injuries and the 3-second obliterations that aggressive titration produces. Subsequently, the consensus statements birthed from SPRINT were extrapolated to every individual beyond 65, incorporating the very cohorts the investigation discarded. The recommendation was constructed on scaffolding that excluded your demographic, and then the recommendation was imposed upon your demographic as though the exclusion constituted a trivial typo. The literature beyond SPRINT narrates a starkly contrasting account. Adults beyond 70 with top numbers, compressed below 120, exhibited elevated all-cause mortality, elevated renal failure incidence, and elevated hospitalization frequency relative to adults maintained between 130 and 140. Adults below 135 suffered greater heart failure events than adults hovering between 140 and 150. Excessive elevation damages. Excessive reduction also damages. The safest band for numerous adults past 70 is not the lowest achievable digit. It is a corridor between 130 and 150, where the myocardium remains guarded and the cerebrum stays perfused, and the lower limbs remain steady upon standing. Yet nobody sketches that J-shaped curve for you because nobody instructed them the curve was there. Now, the evaluation. The solitary procedure you can execute at home tonight that reveals whether your autoregulatory system is compensating or whether your prescriptions are shoving you into Margaret's gap. Seat yourself in a chair for 120 seconds. Obtain your pressure while seated. Document the figures. Rise. Remain standing for 60 seconds. Obtain it upright. Document the figures. If the top digit plunges beyond 20 points or the bottom digit plunges beyond 10 points and you register any sense of floating or dimming, your regulation apparatus is faltering. Carry those paired measurements to your clinician. Utter these precise words. My top number declined by this many points upon standing, and I experienced unsteadiness. That declaration, carrying those 2 values, transforms a brief encounter from worshiping a printout into attending to a person. If you are conducting this orthostatic check tonight, type the word checking in the comments. Let me confront the anticipated pushback because I recognize the resistance forming. First, I am not directing you to discontinue your antihypertensive regimen. Uncontrolled hypertension inflicts destruction. It ravages endothelial linings. It provokes cerebral hemorrhages, myocardial infarctions, and nephron scarring. I am directing you to locate your individual safety zone. The measurement where cardiac protection coexists with cerebral nourishment and postural stability. That figure diverges for every adult past 65. Second, if your treatment renders you lightheaded, feeble, cognitively clouded, or mechanically unsteady, your soma is broadcasting an alarm that the sphygmomanometer display cannot detect. Your symptomatic experience must override the integer every single time. A systolic of 143, accompanied by 0 dizziness, is more protective than 117 accompanied by repeated floor impacts. Third, purchase a self-monitoring device for domiciliary use. Your measurement inside the clinical environment exceeds your measurement at home because sympathetic arousal from the medical context distorts the reading upward. The dosage your prescriber selects derives from the highest spike you generate across the calendar. Gather home readings across 7 days preceding each consultation. Display to the clinician what your pressure resembles inside your genuine existence. Fourth, your physician is not the adversary. Your physician trained on sprint. The instructional syllabus taught a solitary threshold. The compressed appointment structure offers no bandwidth to execute orthostatic assessments, juxtapose readings, evaluate frailty indices, and personalize the target. The apparatus is fractured, not the practitioner. I require you to absorb what transpires the moment this video terminates. You feel equipped. You possess awareness of the orthostatic evaluation and the J-shaped mortality curve and the sprint exclusion criteria. Then, 14 days elapse. You sit in the consultation room. The clinician announces 147. We need to escalate the therapy. You cannot retrieve the thresholds. The clinician scribbles the script. The milligram strength climbs. The disequilibrium intensifies. This is precisely why I assembled the pressure stability protocol. It is not a pamphlet. It functions as the barricade separating you from a dosage escalation your vasculature cannot withstand. The orthostatic test guidance, the age-stratified safety intervals, the precise inquiry phrases, the precise language to deliver, the pharmaceutical interaction grid. All elements structured, so you stride into that environment armored. The path to access it resides in the description area beneath this content. Activate it presently, not after a delay. Because the subsequent instance your clinician reaches toward the prescribing instrument, you require the protocol occupying your grasp, not a hazy fragment of a recording you viewed 3 weeks prior. If your clinician has ever escalated your dosage without inquiring whether you experience unsteadiness upon rising, type the phrase "never inquired" in the comments. I am delivering this exposition because I am exhausted. I am exhausted from witnessing adults beyond 70 strike the ground because a printout displayed perfect while a living being was shrieking for intervention. I am exhausted by femoral neck fractures in adults whose sole transgression was confiding in a target architected for someone 3 decades junior. I am exhausted from observing clinicians layer a second agent and a third agent without a single invitation for the patient to stand upright. I am exhausted from watching the adjective perfect systematically extinguish functional independence. I am exhausted from witnessing consensus algorithms constructed upon a trial that deliberately eliminated frail elders be superimposed upon frail elders as though the elimination constituted an insignificant footnote instead of a foundational disqualification. Yet the collapses and the osseous injuries are not the most profound destruction that overly aggressive pressure reduction perpetrates on your organism. This segment represents what I believe every adult past 60 ingesting antihypertensive agents genuinely requires to absorb. Your cerebrum consumes roughly 15 to 20% of your entire cardiac output. It demands uninterrupted oxygen delivery with each systolic cycle. When the perfusion pressure sinks excessively low, even for a mere 3 seconds upon standing, the oxygen freight sinks in lockstep. You transition from seated to upright 50 to 60 repetitions daily. If each transition generates a 3-second perfusion gap, that tallies 150 to 180 seconds of diminished oxygen delivery every single day. Across a calendar year that accrues beyond 15 hours of compromised cerebral blood flow, across 5 years on an aggressive titration protocol that aggregates to 75 hours of stacked oxygen deprivation directed at the organ safeguarding your reminiscences, your vocabulary, your identity. the mental haze you have attributed to senescence, the retrieval lapses, the lexeme hovering just beyond reach, the acquaintance's name that evaporated, the chamber you entered and instantly forgot your purpose. Those are not normative aging. Those are 75 hours of hypoxic accumulation strung together across half a decade from 3-second intervals nobody ever captured because the cuff digits appeared immaculate from a seated posture. Margaret's daughter confided to me, the cruelest dimension is not the rolling walker, and the cruelest dimension is not the surgically repaired hip. The cruelest dimension is that Margaret's cognitive sharpness has dulled perceptibly. She noted that the fog descended before the collapse. It initiated when the supplementary agent was introduced and the reading descended to 124, and the baroreflex apparatus could no longer sustain cerebral perfusion upon positional change. The brain was being incrementally starved, one transient episode upon another, for months preceding the femoral neck fracture. The wooziness constituted the alert she could sense. The cognitive blunting constituted the injury she could not visualize. Both were generated by a pressure benchmark that was never validated for her physiology. Perform the orthostatic challenge this evening. Transport the measurements to your clinical encounter. Articulate the statement Margaret wishes she had possessed, and steward your vascular health from the foundation upward. And if you wish to learn the single electrolyte your antihypertensive agent has been depleting across years that governs the calcium gating mechanism inside every arterial smooth muscle cell in your body, absorb the content materializing on your display right now, because that electrolyte is the reason countless individuals like you are experiencing cramping, lightheadedness, and dependent edema, while the prescriber keeps supplementing pills rather than checking the reservoir.